This episode is being brought to you by our great friends over at Profi 2020. Profi is a full-service dental CPA firm that provides bookkeeping services, monthly financial reports, managerial accounting services, and proactive tax service to growth-oriented dentists around the country. Profi was born in a dental practice out of their owner's frustrations with the dental accounting industry. Chris Sands actually managed a dental practice early in his career, learning the business from the ground up. During that time, he found that it was nearly impossible to get thorough financial reporting for the practice and even more difficult to get any kind of proactive guidance. That's when he and his business partner, CPA Brent Sonnier, decided to fix it for themselves. Profi 2020 is proactive in a notoriously reactive industry. Most accounting firms, especially in dentistry, deal only with the past. Profi provides detailed reporting, growth-oriented advice, and dental-specific strategies to their clients to ensure that they are positioned for healthy long-term growth. On a personal note, I can definitely endorse Profi as my CPA firm of choice. And the 2 years that I've been with them have been the best in regards to organization and implementing advanced strategies to decrease my tax liability. If you'd like to get started or learn more, schedule your free financial x-ray and get half off the onboarding cost for being a listener of the Dentalpreneur podcast. Just go to Profi, Profi 2020.com/DSI. That's Profi2020.com/DSI.
The Dentalpreneur Podcast. Okay, doctor, it's time to put down that handpiece. You're listening to the show dedicated to helping dentists get their lives back. It's time to decrease your stress, increase your profitability, and regain your passion. Now introducing your host, Dr. Mark Costas.
Hello, everyone. Welcome to another episode of the Dentalpreneur Podcast. I'm your host, Dr. Mark Costas. What's up, my friends? This is another Surgical Saturday. Welcome to Surgical Saturday. So if you guys are looking for practice management stuff, leadership stuff, anything like that, and that is what you're hankering for today, you might not want to listen to this episode, but if you are a dental dork, like the three guys that are on this call today, and you love surgery, advanced surgical procedures, advanced clinical procedures, then this is the show for you. Today, I'm with my great friends, Dr. Dan Brisky and Dr. Taher Doon, who are the founders of the Colorado Surgical Institute. And we're going to be talking about a very specific issue, but something that happens often at CSI. And I think it happens a lot to novice surgeons as well. It is a very common complication, and that is incision line opening. And with that, I will let Dr. Dan Brisky open us up with just a little talk about how often this happens and some of the things that we could do to avoid this phenomenon from occurring during our surgical procedures. Dr. Brisky?
It never happens to me. I don't know what you're talking about.
Never. What does that even mean? What is it?
Can you show me an example? No, even over the past couple of months, I've rethought how I close things, and I've changed my own personal techniques on how I attack full arch procedures, actually, for incision line openings, especially for incision line openings on the lower arch.
Interesting. Okay, cool. Dr. Doon, your reflections on incision line openings, the one time it happened to you.
Not a super sexy topic, but at the end of the day, it's probably one of the most, if not the most common complication people would have in any type of surgery. And it's one of those things that's, teams that like win championships have like the least amount of errors. And this is one of those very avoidable errors. If you take an extra 5 minutes to maybe 20 minutes in some circumstances to really suture the case down properly, you're going to save yourself hours and hours and hours of problems later down the road. Brisky's going to talk about sometimes where it's unavoidable and ways to prevent that also, in terms of what you can do pre-surgically, which is a pretty cool thing he talked about or will talk about. But at the end of the day, it's really like picking your product and your material for the scenario correctly, and then making sure, like, when you first tie that first throw, you can tie it one way and it ties down all the way. Or if you tie it in reverse, it looks a little bit jumbled and backwards. It's just making sure your first throw actually ties down in the right way and it's not backwards or inverted. Because a lot of people just need to improve that one thing and their sutures would stay tied down really, really well.
I think it's worth noting that, after a long surgery, we see this at Colorado Surgical Institute all the time. After a long surgery, there's been that huge kind of adrenaline dump. You're in there for a long period of time with the patient. You are doing things for the very first time. So that is mentally and physically exhausting. By the time you get to the end, all the implants are placed, all the bone graft is in place, the membranes are in place, PRP has been, deployed into its appropriate spots. And all you have to do is close, but you're tired. And I think that a lot of times we don't spend enough time with this very, very important step in order to ensure that this doesn't occur, because it is the most common cause of failure for these complex cases. So,
over those weekends, Mark, I saved my second Red Bull for the day, for the end of the day, so I can go room to room and then fix about 50% of them. So that way you can, because everyone, like you said, everyone gets a little bit lazy, right? And then we all think we're absolutely amazing at suturing, and none of us are. So I think we spend a lot of time at the end of the surgical day is just, I'll chug a Red Bull, then I'll go room to room, and then me and Dune will just go in and be like, hey, like, what would you change about this? What would you change about that? Then we'll cut about 30% of the sutures out of the rooms, and then we'll like resuture everything when everyone's tired.
Yeah, one of my favorite mentors is Dr. Michelle Caldwell. She actually taught me how to do lateral sinus lifts. And I think that she doubles your percentage, and she'll cut out about 60% of the sutures that she sees, and she has them start from scratch again. Not in a nice way. I mean, the kindest person in the world. She just wants to make sure that she's driving home the importance of closing an incision line correctly. So, where do you guys want to start as far as the common mistakes and potentially what we could do to avoid them?
Yeah, one thing before we hop into that is you addressed something about being tired towards the end of the surgery. There was a time that I used to go take Alpha Brain, like midway through the procedure, or you can take, like, you can get some coffee in between. You can go for a walk. You can, take a scoop of C4 if you like that pre-workout stuff and really get juiced, but do something to kick your energy level up if you start to run out of steam on these surgeries. When me and Brisky were practicing together, we'd be done with the double arch and we'd be exhausted, and we would just suture each other's cases and help each other out. Because there's a version of like, hey, if you're fresh and you got someone like an associate or a partner or someone who can help you out at the end of these cases until you got the endurance to persist through like 4 arches a day, then at that point, it's nice to lean on people also.
Yeah, I love that. That's a good strategy. So Dan, you said that you recently changed your procedural mix, or the actual procedure of closing. Was that based on something that you had learned, or just some quiet reflections on some of the incision lines that had opened on you?
Quiet reflection for sure. We had throughout the last 2 full arch courses and throughout my startup, because I just opened a startup about 6 months ago. I just had my 6-month anniversary this week, actually.
Congratulations. It seems impossible that was 6 months ago. It's crazy.
Yeah, right. And I've done now 17 arches at the practice, or 18. And between my arches at the practice and the arches at the Surgical Institute, over the past year, I've noticed the common trends of why things have opened, especially for all on X on the lower. And I have a new protocol that I do now in terms of giving patients Botox as well. So nowadays, there's an overdenture. Let's talk about the mandible first. So on a mandibular case, and you're doing an overdenture or an all-in-X, it's very important to not have incision opening, right? And if you do, let's say you have an incision opening on the lower all-in-X, and you pull the lip out and you see white bone. At that point, biology is going to attack the implants, and you're going to get bone loss. So you have to resuture it. And I think I was way too casual back in the day, like, oh, that could granulate in, or you see a lot of people will post an all-in-X on Facebook and like, hey, it opened up, and a lot of people would be like, hey, just let it granulate in. But what they're forgetting is biology is going to attack the implants, and they could end up losing all those implants because they didn't resuture, right? Because the bone is going to remodel downwards. So I definitely advise everyone to resuture everything and not let biology attack it. So the first thing I do is I'll pull the lip out gently, and I'll see if I can see white bone. If I don't see white bone, I am more inclined to just let it granulate in, or I'll see the patient every 2 to 3 days. I'll rinse it with them, and I'll apply an antibiotic gel called metronidazole gel to that lower incision line. So basically, you're keeping the implants from being infected and the tissue from being infected until it granulates in. So that's what you do. So you just keep it infection free. But if you see it open, then I would go back and reclose it. But when you reclose it, you have to add at least 2 layers of PRF over the top of the bone, because the first one will dissolve, and then the second one will actually stick around a little bit. So I'll put 2 layers over it, but then I'll close it. But even throughout the years, I've seen some cases, some patients will still destroy that even, because you'll get, historical patient, they'll say they're not doing anything, but then they'll tell your staff that they're brushing the incision line, or they're applying Oragel to it, or they started water picking on the 3rd day, or they'll do anything to mess your stuff up, right? So nowadays, I'll actually Botox my patient. I just started doing this last month, actually. So I'll give Mentalis Botox and DAO Botox, and also a little bit on the lower border of the lip. And I'll do that 10 days prior to an all-neck surgery or an overdenture surgery to protect from lower incision line openings.
So interesting. Where do you apply that? The Botox, not the lower lip, but the mental area.
So if you picture a chin, and some people, when they scrunch their chin, it looks like an orange peel. Those are the ones that you want to be doing the Mentalis injection on. And you're going to do it in a perfect triangle. So you're going to do a triangle, 1 a little on the superior border of it, and 2 on the base. And just picture a triangle, and you're going to do 3 dots. But you're also going to do about 2 units in an area called P5. And this is where the depressor anguli oris and the DLI will pretty much combine and be in around the same spot. The DLI muscle is what causes a droopy lip, so you can't hit that. So there's a specific area where you just inject about 2 to 4 units in, called the P5, and that will paralyze the muscle, but you won't get a droopy lip. So that way you can attack these patients. So that way, they can't scrunch their lip, they can't make a frowny face that will actually have an incision opening applied to it. So I just started doing that. And the ones that have opened in education have actually been all lower incision line openings. I haven't had any that were upper.
Interesting. Dr. Dune, reflections.
I would agree with Dr. Brisky in the fact that it's very rare to have a maxillary incision line opening. I mean, it happens from time to time. More so than not, what you may notice is just because the maxillary tissue is so thick and robust, typically speaking, that's not going to pull and open. And the maxilla is fixated to the skull. The mandible is what's actually mobile with more musculature that attaches to different angles of the mandible. And the tissue is just friable. People call it like tissue biotype, and we're hearing some periodontists and some literature calling it a phenotype now. But the biotype or the phenotype of the tissue and the thickness of the tissue, the lack of keratinized gingiva in the mandible is going to kind of dictate, more incision line opening there. So just be very attentive to suturing, especially in the mandible when you're doing it. And if we kind of get more granular and talk about hey, if it's a single implant, how do you want to suture a single implant or a single socket preservation site? Would you put in a horizontal mattress? Would you put in 2 or 3 interrupteds? I like to view things, and I'll make relation to the aviation industry sometimes, because they have triple redundancies, within aircrafts for regulatory reasons. But we can kind of take notes from them and say, hey, well, why don't we just put a redundant suture in there in case one opens up? So I like to do a version of a horizontal mattress and maybe 1 or 2 interrupteds around a single implant or a socket preservation. Brisky, what do you do around one of those?
Single implant.
Yeah.
I just do simple interrupted for the most part.
Just two of them?
About two of them. Yeah. You can do a horizontal mattress between, or going around the healing abutment. Mm-hmm. That would work as well. But I think the part where people forget are, like a suture selection. So what I've noticed in full arch and all the classes is if we're using a 5-0 to suture the full arch, it actually dissolves a little bit faster. So once acid hits that incision, that type of suture, it's resorbable, right? So if we're using resorbable suture like a glycolon or a PGCL, acids will break down that suture. So I've noticed substantial increase in openings with a 5-0 than a 4-0 even. So I advise everyone to use a 4-0 suture when they're doing full arches instead of a 5-0. That is even one thing that helps. And like what type of suture you're using, and does it actually cinch down? So when Dune and I go check rooms at the end of the day during the surgical courses, I'll take a cotton forceps and I'll pull up on their sutures. And if there's a lot of room and I can pull their suture up in the air, then I just clip them out of there. Because at that point, it's not serving any purpose. Because if there's space, once I pull up, once inflammation hits, the entire incision is going to be open because there's nothing holding it together.
Yeah, I think what you can do is when you do your first throw on your suture, like I said in the beginning, make sure it ties down the right way. But then secondarily, have your assistant have like a little tissue forceps or cotton forceps, and they can just put their instrument on your knot. Almost like back in the day when we learned to tie our shoelaces, someone just puts their finger on the knot so it holds it in place. Then you do your second throw and tie it down. And that works really well up and until the point that you get really comfortable by yourself, and then you don't need that assist anymore. On my single implants and socket preservation, I'll use like PTFE suture. You don't have to. You can use a PGCL, but I'll use a non-resorbable suture that's like a 4-0 PTFE, cytoplast suture for my single sites. And then if I do full arch, I use a 4-0. I know some people use 5-0. For my full arches, I'll use a 4-0 PGCL. Because I like the way it ties down. And when I do a full arch, I'll do like the Texas 2-step, which is a series of horizontal and continuous within one quadrant. So one pack of suture for one quadrant, but I'll save a little extra on that same suture pack, and I'll throw at least one or two interrupteds in there as well. So again, it's just my redundancies in there. If the patient pulls something, I got a couple extra sutures holding the whole thing down.
This episode is being brought to you by our good friends over at CareStack. CareStack is the all-in-one cloud-based solution for seamless scheduling, efficient insurance verification, and in-depth analytics and reporting. Get a deeper understanding of your business with streamlined revenue cycle management and comprehensive clinical notes, all designed to elevate your practice to the next level. Visit carestack.com today to book a free demo. Tell them I sent you and get 2 months free when you switch over. Carestack.com, CareStack.com.
Okay, so that was a single or, single site or onesie twosie sites. Let's talk about closing a mandibular full arch. I guess specifically I would ask, just for visualization purposes, are you guys taking this in one quadrant at a time and closing one quadrant at a time? Or are you going to do a continuous all the way across the entire arch? And are you starting in the anterior or posterior region when you're closing?
Yeah, good question. I mean, and this is how I do it, and I know Brisky will probably be a little different. It's not, if I'm doing an edentulous arch, I'll just do one across the whole thing, and I'll save a little extra and do a couple interrupteds. But if I have implants placed on the full arch, then I'll do a one pack per quadrant, and I'll suture in between the multi-units with a Texas 2-step approach. And I'm making sure that the needle is going through the keratinized tissue. Mm-hmm. I don't like grabbing too much of that mobile tissue unless like none exists. And then you should be considering like, a free gingival graft or connective tissue graft or something to thicken up the tissue into the future. But either way, to suture that specific case where there's a little bit of KG present, I like my needle to throw through that specifically. because you're less likely to have it tear versus the mobile mucosa.
So I drew in the picture like just a lower full arch, and the bone's really open all the way from second molar all the way to the anterior portion. If you're going to close it, first you have to make sure you can close it. So I would first test and take the cotton forceps and bring it to the lingual and say, hey, if I suture this, is there enough tension-free closure where it's not going to reopen, right? And if the answer is no, which a lot of the time it's not, you have to do a periosteal release, right? So you take your 15, you're going to make a nice incision in the periosteum. That's going to create room where you can get tension-free closure. And then what I see a lot of time is if you start suturing from the interior portion, by the time you get to the back, will the tissue be reapproximated perfectly? A lot of the time is no. So sometimes I'll tell students to place a simple interrupted, like one in the front and one in the back, just so that way you're just starting to tie down the tissue enough to where your brain can start seeing where things need to come together. Then I'll grab one suture pack per quadrant, one for the right and one for the left. And I'll take that suture, usually a glycolon or PGCL, a 4-0, and then I'm going to tie a simple interrupted, but you're going to clip the small end, but you're going to keep the long end, right? Because you're going to use the rest of the suture for the entire quadrant. And then I'm going to do exactly 2 to 3 horizontal mattress sutures. So what you'll do is you'll move over about an inch. You're going to go through the buccal and then through the lingual. And then you're going to move down about another 2 inches over, and you're going to go through the lingual and then through the buccal. Then I'm going to go another 2 inches over. I'm going to go through the buccal, through the lingual. And then once you get to the posterior part where you already tied it down, you're going to start going to do a continuous. And I don't do locking because I think it just takes a lot longer and I haven't really seen a big benefit from it. So I'll do a loop. Now I'm on the lingual. So now I'll go back in towards the buccal and I'll go out towards the lingual. So that forms a loop. And I'll keep doing that all the way back around. And I'll make a continuous suture every, I'd say probably like 4 millimeters. So I'll go buccal, lingual, buccal, lingual, buccal, lingual, all the way back to the front. And then I'll tie it off. And after I tie it off and clip it, I'll actually still suture more. I'll grab whatever's left of that small thread, or I'll grab and I'll put 2 simple interrupted, maybe one in the canine area and one in the premolar area, just so that if doomsday hits and the patient wants to brush the incision line, at least one of those sutures are going to hold.
Yeah, I love it. That triple redundancy, just like aviation that Dr. Dune was talking about.
Yep.
So, is there a situation when you guys would take this a quadrant at a time and not close the entire arch with one continuous?
I actually always close it by quadrant. Personally.
Oh, you do? Okay.
Always. I do personally, because I feel like if you use one pack of sutures for the whole arch, what are the chances of that whole thing sticking around versus more redundancies where you do a pack of sutures per quadrant?
Gotcha. Okay. So, let's talk about the situation when this just won't close. So we talked about the periosteal release. What if even with that, you're having a difficult time getting primary closure? Are there further, protocols that you guys would suggest?
Are the implants placed or the implants not placed?
Yeah, the implants are done. Surgery's done. Basically, you're just closing.
Oh, okay. And this is just like trying to get the tissue to close, or is it the patient came back with it open?
Both. Let's do both scenarios. Yeah.
So I'd say if you can't get the tissue to close after you did a periosteal release, it's because you didn't do enough periosteal release. And we see this all the time. So what I'll do is I'll take a tissue forceps and I'll reach underneath the tissue with a curette, and it'll be about 10 millimeters from the free gingival border. I'll go down, and this is usually at the level that your periosteal releasing incision is at. And then at the same time, I'll pull up with my tissue forceps at the same time that I go into the tissue with the curette, and I just pull up, and that will actually tear the periosteum more. So I've seen a lot of docs find that a little bit easier or a little bit quicker to do, and you go back and you just do that throughout the whole arch. That's actually really fast. You could probably do that in like 2 or 3 seconds when we show people, and every time we do a surgical course, I think that's one of the most important parts to see is how do you go from no tissue closure to, you could pull the flap and touch their nose with it.
Yeah. Got it.
Pretty much in any surgery that you're not fixing, but you're trying to close something, you should be able to close almost any scenario. There's a few and far between that if you do your first periosteal release, like Brisky said, that you can't close it. It's usually there's some of these vertical fibers that are still attaching the periosteum together. And if you take, a pair of scissors or a scalpel or your curette and you move it horizontally within your incision and you catch all those vertical fibers and pluck all of those vertical fibers, you'll feel it release and everything will come up. And then the goal is after that is you got to keep it closed. And then that's good patient education. But if they come back from the surgery and the incision line's opening, that's where it gets more dicey because resuturing already traumatized tissue is very hard to do because the tissue tears very easily. So I like a complement of more PRF. We'll do more blood draws. We'll spit down more PRF. I might utilize a membrane specifically in some circumstances underneath also. And then you got to release the tissue and do an excessive amount of it very carefully, or you're going to keep tearing it. And you make a huge periosteal release, and then you reclose it. And then using metronidazole and some different products that Brisky talked about, you can medicate the patient and help them keep them closed. But Brisky's closed a lot of these for CSI and these mandibular ones. So is there anything like specifically you like to do in a surgical, like incision line opening case like that?
If you can see the bone, then I would reopen it all, and then I would add 2 layers of PRF for sure. One will resorb, so I put 2. And you have to keep track of what you're adding. I wouldn't add a lot of things, so I wouldn't get in the habit of trying to rebone graft something or add a bunch of membranes or adding things. So the more things you add, the more hard of a time you're going to have to close it, right? So I'll go really simple with my closure because your brain should be thinking, oh my God, I don't want to lose any implants. I don't really care about that spot that I need the graft. So I would think like that. So I would place 2 PRF membranes over the areas that are exposed. That way, if it does open, it will still granulate in and being infection proof. So I'd still do it by quadrant. I would do a huge periosteal releasing incision, probably use a curette to stretch the tissue more. Do a quadrant of sutures per side, and I would still put about 3 simple interrupteds on that side as well, all with a 4-0, because that way it'll tie down a little bit better. Over the top of the incision lines, I'll actually use glue stitch or periapical glue. So I'll glue the incision lines back together. And after I put the prosthetic back on top, if it's an all-on-X, I'll glue the tissue to the prosthetic as well. So literally everything that you can think of. And on that same patient, if they open it once, I'll probably Botox them on that same day. But nowadays, I actually Botox all lower all-on-X patients because it's going to cost about, I say you're going to be using about 10 units, and 10 units comes out to about $100. I would rather spend $100 to Botox an all-on-X patient on the bottom and prevent an incision line opening from the beginning.
Yeah, and you spend the rest of the 90 units from that vial on your staff as a bonus.
Or on your own wrinkles because you had this incision line opening.
So we probably already covered this. You talked about metronidazole gel. What's your favorite method for removing debris? Say there's food or plaque or something that's kind of infiltrated the area and it's kind of a mess when you get it. Are you just using saline or chlorhexidine? Or
good question. I use a monojet and I use Closis rinse in it. Or you can use Stella Life. I'll use something that is a hypochlorous acid. I won't use chlorhexidine anymore because of how cytotoxic it is. So the most natural thing you can use and the best wound cleaner is definitely a hypochlorous acid. So I'd say Closis. Closis is a periodontal rinse or Stella Life. I use that in every surgery. So I no longer keep chlorhexidine in my practice.
Oh, cool. Okay. Dr. Dune, anything further to add to this awesome discussion? You guys are doing a great job talking through this in an audio only format. This is great.
Yeah, I appreciate that, Mark. I think, what I'd recommend is every incision line opening can kind of be a little bit different based on how the patient presents, size of the mesenteric muscles, mentalis muscle, habits. Are they old and have dementia? Are they not? I mean, there's so many factors that go into it. What I recommend is, for anyone who wants to reach out to Dr. Brisky and myself, you guys just find us on DSN and message us. You find us on socials and message us. We'll set up a time to talk, and we can help kind of just demystify this. And once you see enough of them, if you do enough surgery, you're going to have incision line opening no matter what. It's just going to be few and far between. But the goal is to talk to people who've done it and closed a lot of them. And through CSI, we get to handle probably more complications than most private practice owners because it's just an educational type of experience. And we do a lot of stuff in one weekend. And we'll be able to help guide the decision-making process or even just confirm. Maybe you come with the perfect plan and we're just there to confirm that you had the right plan in place. So we just, urge everyone reach out to us because we are here to help and hopefully help your surgical journey not be, riddled with a whole lot of sleepless nights.
And it's not only about how you close it, it's how do you prevent the infection? So a lot of time you can nurse cases along to where they'll become healed and you don't lose anything. Mm-hmm. I think that's been an art that we've definitely gotten down. I've only lost 2 implants in the private practice, knock on wood, out of like 140 now that I've placed. And nice. I think that's pretty good, but it's because I know how to keep things from being infected with the right rinses, with the right antibiotics, with the right antibiotic gels, with the right suture techniques, with the right glue stitch. And it's when do you save that ammo for what case and what scenario? And that takes years and years to learn. But Dude and I are here to try to help people get there way faster than we did.
Yeah. And I will say, practice doesn't make perfect. Perfect practice makes perfect. So, you just like anything else, if it's prepping a crown, a class 2, taking out a tooth, placing an implant, doing an all on X, closing an incision line, if you learn how to do it correctly from the beginning, it may take a little bit longer to learn the proper technique and to actually execute. But, just like with anything else, you're going to be super fast and super proficient in some time anyway. You might as well start correctly from the beginning and decrease the likelihood that this could happen. I just love the fact that you have 5 different layers of protection, Dan. It's pretty cool. You got glue, you got double glue, you got 3 different types of suture. It sounds like overkill, but I'm sure it greatly diminishes the rate of openings that you've had.
Yeah, right.
Yeah. One thing I want to add is no more silk. If you're using silk, please I'm not an advocate for throwing anything away, but I would say just use it to tie back a flap mid-surgery so you can use it because you're going to cut it out and not send it home with the patient.
Mm-hmm. They're also really good for repairing teddy bear rips. I've had to do that when my kids were younger. Use silk. It works very well.
Yeah, you can practice at home with your silk. That's perfect. And then chromic gut. I use chromic on my wisdom tooth cases because, you just need a single. It's cheap. You just need to hold it closed for a couple of days. And these kids heal so fast. You can barely see the incision line in 1 week. So use your chromic there. And then outside of that is really, Glycolon and PGCL and PTFE. And that should really be your workhorses for really any type of surgery where you need to hold it closed for a long period of time.
Love it. All right, boys. As always, awesome stuff. Dr. Dune, where can they find you and how can they find out more about upcoming Colorado Surgical Institute courses?
So if you're on the Dental Success Network, then Dr. Brisky and myself are faculty on a lot of the forums, surgical forums. So reach out to us there. If you're not on Dental Success Network, look into it. It's a beautiful resource, but you can reach out to us on social via coloradosurgicalinstitute.com, Instagram, Facebook, all the usuals. Daniel Brisky or Taher Dune. That's DHOON. So I'm literally, I think the only Taher Dune in the world. So if you message one of them, it's going to be me. And we're here to help you guys.
All right, fellas. Thank you guys so much for taking the time. I know you were busy to get today. It's a rare treat to get you both in the same room. So we really appreciate everything you do for the DSN community, the podcast community, and for dentistry in general. Ladies and gentlemen, Dr. Taher Dune and Dr. Dan Brisky.
Hey doc, quick question. How's your office doing on Google reviews? Do you struggle to get patients to remember to leave one after they have left the office? I just wanted to share the newest offer from the Dental Success Network, custom NFC cards. Our members are finding that by using these simple cards, they can get patients to leave reviews before they are out of the office. All you have to do is train your team to make a simple request, then tap the card on the back of the patient's cell phone. Your Google review page will pop right up and they can take it from there. DSN is now offering custom NFC cards for your office. All you need to do is visit dentalsuccessnetwork.com/NFC. Fill in the info and we'll get your custom card out to you today. Again, just visit dentalsuccessnetwork.com/NFC and get more Google reviews today. And that wraps it up for another episode of the Dentalpreneur podcast. Look forward to reconnecting on the next episode.
Thank you so much for joining us today on the Dentalpreneur podcast. Check out TrueDentalSuccess.com for full recaps of every show, a schedule of our live events, free video tutorials, and a whole host of practice building resources.